very good morning to everyone. It gives me great pleasure to introduce Dr. Sakina Ghauth, our second presenter for this morning. She's one of our lecturers in the Department of Otorhinolaryngology. She completed her master's in 2018 and has a subspecialty interest in head and neck surgery. So she's completed her fellowship in Thailand and is currently developing her interest in reconstructive surgery in head and neck cancer patients. So her talk today is on tracheostomy care. Are we on the right track? So Dr. Sakina, you can start your presentation.
Thank you for the kind introduction. Yeah, you can hear me, right? Yeah. Okay, thank you so much. Can you see my slides?
Yes, we can.
Okay. Let me just
feel free, everyone, to put your questions in the chat box, please, or the Q&A box. Thanks.
Okay, thank you so much for joining me today. Well, my topic today, tracheostomy care, is not as interesting as the first presentations. It's kind of boring, but nevertheless, we see this very frequently as ENT surgeons, and this is something which is very important. So this is thus the outline of my presentation today. First, I would like to talk shortly about a case scenario, and then I'll talk about what is tracheostomy, the indications and applications related to tracheostomy, and just 4 important points in effective trachea care. And lastly, I'll talk a bit about weaning or decannulation. Okay, so let's start with the case scenario. Okay, so Mr. X is a 66 years old Malay gentleman with multiple comorbids, hypertension, recurrent CVA, sacral aneurysm, recurrent stroke. And so this case was initially referred to us on an outpatient basis for some other problems, but he was admitted in June 2022 for some elective cardiac surgery. However, complications happened. He developed new onset of stroke and pneumonia, in which percutaneous tracheostomy was done in view of failure of extubation. And because of that, he was referred to ENT for tracheostomy care. So subsequently, he was well and he was discharged 1 month later with a tracheostomy, but upon discharge, his family was educated on trachea care, and he was referred to the speech-language therapies for swelling assessment as outpatient. But however, somewhere in July, which was about 2 weeks later, after the discharge, he presented to emergency with tracheostomy block. And at that time, we noticed that there are a lot of mucus block inside the tracheostomy tube. Hence, we cleared that off and we emphasized on trachea care again to the family members. So again, in August, the outpatient speech-language therapies appointment in which they did a fiber optic endoscopic evaluation of swallowing. So what is this basically is, the speech-language therapists, they will, together with the ENT surgeons, the ENT surgeons will do a scope, then the speech-language therapists will try different types of food, starting with fluid, then the thicker version, some puree and all that, to see whether patient can swallow well. However, patient failed the test. We noticed there's some aspiration and penetration, hence it's not safe for oral feeding and decannulation. Then in October, surprisingly, patient was admitted to primary team for decannulation, and the patient was referred to ENT for decannulation. But having said that, the patient already failed swelling assessment. Hence, during that time when we scoped the patient, there is still obvious aspiration going on. So patient was not safe for decannulation. Hence, the subsequent follow-up, there surprisingly, even though patient had been admitted many times, we have seen the patient a few times in clinic and even in the ward where we already talked to the family and the patient regarding tracheostomy care and all that. Still at the last follow-up, they are not aware about tracheostomy care. So, well, very simple case. We see these very frequently. So what I'm trying to highlight here. So number one is decannulation is something, primary team should know. Everyone should know about that. Before patient actually going for decannulation, patient should be informed regarding the process of it, and whether or not, at the end of the day, whether we can actually wean off the trachea based on a proper assessment. This proper assessment includes a proper scope, proper swelling assessment to make sure that everything is all right before we actually remove the trachea. And a lot of patients, even though we have educated them regarding trachea care, a lot of them, they don't really think it's important. So a lot of time we try to, talk about it every time, even every follow-up. So this is very important. And the emphasis regarding trachea care is not just by the ANDT, it should be done by other teams as well. Okay, so what is tracheostomy? Tracheostomy is basically an incision through the anterior part of the neck into the trachea that forms a temporary or permanent opening for ventilation. So hence, instead of breathing through the nose and mouth, the patient will now breathe through the tracheostomy tube. So you can see here on my slides, there are many types of tracheostomy tube. The one on your left-hand side, that is a double lumen uncuffed tube. So usually we use this for long-term patients who requires long-term tracheostomy. On the right upper part is the cuff single lumen tube. Usually we use this for ventilated patients. And the right lower part is the double lumen metal tube. We don't really use this commonly now, but this still being used in certain places like Thailand and India. So when do you do tracheostomy? So a lot of reason when prolonged ventilator support, people with upper airway obstruction or edema, when you have a lot of excessive pulmonary secretions where they need a lot of tracheobronchial toileting, with bilateral vocal cord palsy, in which I mean abductor palsy, and sometimes in the prophylactic prior to extensive head and neck surgery. Hence, the indications of tracheostomy can be permanent or temporary, where permanent tracheostomy was done, the chance of the patient to regain their normal airway function is low. Okay, so what are the complications? Can be early and late. So the one in bold, which is bleeding and block, that is the most common complications that happen. Other things like infection can happen as well. Dislodged, false Trach, pneumothorax, and emphysema is less common. Late complications, airway obstruction, which usually happen because of poor nursing, poor care, infection, dislodged tube, fistulas, and necrosis. So in my slides, this is, I think, the most important things you need to know for 4 important points in effective trachea care. So starting from how to take care of the skin or stoma. Stoma is basically where we put the tracheostomy. Number 2 is the tracheostomy tube itself, how to take care of that. Number 3, how to do a proper suctioning for all the secretions. And number 4, dealing with emergencies related to tracheostomy. So skin and stoma care. I mean, as we all know, we have to take care of the skin to make sure to facilitate wound healing and to prevent infection. And all the, the dressing and tapes around the stoma should be changed daily. And we should, this should be changed daily or whenever solved to prevent maceration of the skin, maintain skin integrity, and minimize the risk of infection. Hence, early detection of stoma infection will help to maintain the integrity of the skin and also to prevent infection. So what are the signs of infection? So excessive leakage of secretions, false smelling coming up from the stoma area, erythema around the stoma site, and also erosion of the stoma and tissue loss. Okay. So when I say about excessive leakage of secretions, we are talking about secretions from the tracheostomy itself and especially from the sweat. Okay, what are the risk factors? So excessive moisture at the tracheostomy site, obesity, pressure from the base plate of the tracheostomy tube, and this usually happen in obese patients, poor nutritional status, and immunosuppressive patients. Okay, so if you look at these both picture, both are basically infected tracheostomy wound. You can see the base is very sloughy, the stoma area very sloughy, there are yellowish secretions coming out from that area, and the surrounding skin is inflamed and red. So these two are the example of infected tracheostomy, infected stoma. Okay, second important thing is tracheostomy tube care. Okay, like I mentioned earlier, we have a few types of tracheostomy tube, but two most commonly used tracheostomy tubes are the single cuff and the double lumen uncuffed tube. So single lumen tube is usually for ventilated patient or patient who we just did tracheostomy for them. So, so again, mainly used for ventilated patient, and as you all know, they have cuff. Hence, this cuff pressure should be maintained around around 15 to 25, and the inflated cuff is on. We recommend the inflation only if medically indicated. So this constant unchecked cuff pressure and overinflation of the tube may cause mucosal necrosis or stenosis. Hence, patient can develop, stenosis like the picture the picture on the right side. That is the stenosis happen. It is a circumferential stenosis happen at the trachea. Okay, what happened if underinflation happened? So the cuff fails to make an adequate seal and the patient is at risk of aspiration. So just inflate the cuff only if indicated, especially in a patient requiring positive ventilation or high risk of aspiration. Okay. Another type of tube is double lumen tracheostomy tube, in which we usually use in patients requiring long-term trachea. And if you look at the picture on the right side, the outer cannula, which is the first one, and the second and third one is the inner cannula. The inner cannula is slightly longer than the outer cannula. So why is it slightly longer? So that whatever secretions can build up at the inner cannula, and hence we can remove the inner cannula and wash it with sterile water. So this inner cannula should be checked every 6 hourly to ensure patency and clean with a sterile water. So how frequent do we need to change the tracheostomy tube? For a single lumen tracheostomy tube, the cuff tube, we usually change it every 2 weekly. The first change can be after 7 days of operation or 2 weeks after the operation, and subsequently every 2 weekly. So until patient doesn't need any more ventilation or any more surgery after that, then we will change to a double lumen tracheostomy. Double lumen tracheostomy, on the other hand, we usually change every 6 months, and sometimes we change it earlier, especially if it's very dirty. We see there's sign of infections and all that. Okay. Third important thing is suctioning. Okay. Well, suctioning should be performed based on the patient's respiratory status, the consistency and the secretions, and the patient's ability to cough and clear secretions from his or her airway. And this should be done under aseptic technique. And closed system tube is recommended to maintain ventilator pressure in ventilated patients. So important things about suctioning. Number one, what type of tube should I use? Okay, so we have different types of catheter for suctioning. We have multiple side holes and single side hole, in which multiple side hole is preferred. So why is multiple side hole preferred is because it causes less damage to the tracheal mucosa, because it's dissipated the focus of the suction pressure, making it less likely for the mucosa to be suctioned into the side holes. So, and then the pressure and the size of the catheter as well. So this is a simple formula to roughly guide what is the size of the catheter. So for example, if your the inner lumen of the tracheostomy is 8 mm, you divide that by 2, which is 4 mm times 3, which is 12 mm. So if you look at the picture down below, the proper size is the one in the green, which is half than the inner diameter. The red one is the wrong suction catheter size. Okay, so the technique. So we have to make sure the pressure is correct between 80 to 120. What happens if high pressure? The high pressure can cause atelectasis, mucosal damage, and catheter collapse. And allow patient to breathe or cough in between suctioning. And try to perform suctioning not more than 15 seconds, as prolonged suctioning increases the risk of hypoxia and trauma. So, and try to provide some trachea mask to allow patient to breathe humidified oxygen between suctioning. Observe for patient response. Don't do suctioning without looking at the patient. Make sure to check for any sign of respiratory distress, and repeat procedure as necessary according to the patient's tolerance. So what happens if patient, have very copious secretions? You can start other things like normal saline nebulizer or hypertonic saline nebulizer. Please try to rule out whether the patient is having some lung infection, hence patient requires some antibiotic. And you can also refer the patient for chest physiotherapy, especially bed-bounded patients, stroke patients, and geriatric patients. Okay. Another good question is how deep to suction. Okay. So a simple rule is that normally you just need to insert 1/3 of the catheter. So you measure the catheter, the picture on the right side, the right upper side. That is the length of the catheter. So you just take 1/3 of it, and that is how much you can insert. Or another way is you just measure the length of the tracheostomy tube, and that length of the tracheostomy tube is how much length of the catheter that can go in. Yeah. So why is this very important? Suctioning is actually very important because a lot of complications happen because of suctioning. Main complication is bleeding. Initial part will cause fresh bleeding, so people get very scared, so they will start referring to us, and we have to rule out whether there's any fistula going on, whether is it from the innominate artery and things like that. But late, what happened? All this bleeding come crusted and hardened. So if you look at the picture on the right side, all that is basically a crusted hard blood inside the tracheostomy, in which we can't remove it in bedside. So we had to go into OT and remove it in general anesthesia setting. So granulation tissue can develop at the tip of tracheostomy tube. That is another complication. Infection can also happen, and hypoxia can happen as well. Okay. The last important things to know is emergencies related to tracheostomy. Of course, there are other emergencies related to tracheostomy, but these two are the most common ones. Number one is block. Number two is dislodged. So why does blockage happen? Usually due to mucus plug and thick secretions, and sometimes due to blood, and worse is granulation tissue that develops at the tip of the tracheostomy tube. If you look at the picture here, that is basically at the center, that is the granulation tissue. The surrounding part is actually the tracheostomy tube. And you can see the granulation tissue is basically obstructing the tracheostomy tube almost 100%. So how to identify a blocked tube? So you hear noise, okay? Every noise sounds like a gurgling sound. You look at the respiratory rate, there's increase in respiratory rate or drop in saturation, and you can't pass your suction tube through the tube. And you can do a simple test, like you feel for air blast from the tracheostomy tube, or you can just put a piece of tissue or a cotton in front of the opening of the tracheostomy tube, and you look for the movement of this tube. Okay, so what can you do? If the patient can cough, ask the patient to cough. If you can suction, apply suction to remove all the secretions. You can remove the inner cannula because usually the secretion is stuck at the inner cannula. And if all that fail, so you prepare to change the tracheostomy tube, or you start to do oral intubation. So the second most common emergency is tracheostomy dislodged. It can be partial or complete. So tracheostomy dislodged means unintentional or unplanned tube removal. How to identify partial dislodge is you are not able to suction, or there is no air blast coming out from the tracheostomy tube, or you can see the tracheostomy is partially out. So if it's a complete dislodge, the tube is just totally out. So what can you do? You have to stay calm, call for help, assess the patient breathing, try to deflate the tube, the cuff tube, reinsert the tube, and lastly is prepared for oral intubation. Okay, last part of my presentation is regarding weaning or decannulation. So what is weaning or decannulation? We use this term very frequently. It is basically a planned process to revert the patient to breathing normally without a tracheostomy tube. And normally, if patients suitable for decannulation, the patients need to be admitted for close monitoring. And this is something which is involved multidisciplinary because normally the tracheostomy is done due to some other problems which is not related to ENT. So the primary team should already explain to the patient what are the process, what is the steps, when can we decannulate the patient, because all these are very common questions asked by patients and the family. So what are the criteria for decannulation? So number one is reversal of the medical condition that originally necessitated the tracheostomy. For example, if patient have upper airway problem, so that already settled. So good lung function, patent upper airway, patient able to cough and clear airway secretions. Again, adequate swallowing evaluated by the speech language therapies or proper assessment via fees, and absence of respiratory infection. So what are the steps? Again, patient need to be admitted. We usually change, there are different techniques, but normally we use uncuffed fenestrated tube and spigot, the outer opening. Spigot means close the tube or downsize the tube. Then we monitor for about, monitor for breathing and saturation for 24 hours. Then we remove the tracheostomy tube. Then we monitor again for 24 hours. Then if everything is all right, we discharge the patient to follow up. So that is the last part of my presentation. So again, what I would like to emphasize is tracheostomy care education should start early, even when you take the consent for the tracheostomy tube. You should already explain to the patient that tracheostomy care is not the job of just the doctors and nurses. It's also for the patient and family, because when the patient go home, if they go home with a tracheostomy, patient and family should know all these 4 important points, and they should, do all this and make sure all these complications doesn't happen. So with that, thank you very much.
Thank you very much, Dr. Sakina, for that comprehensive presentation, highlighting the challenges of patients with tracheostomy. And as you've rightly pointed out, blocked tracheostomy tube and dislodged tubes are the commonest reasons why ENT on call gets summoned. So let's go to the chat box. Okay. So Dr. David is asking if we can refer patients with motor neuron disease on long-term ventilation, especially to trained carers and family members.
Sorry, where is the question?
So basically, about training family members.
Yeah. So for that question, actually, we do have a special team. We call it a tracheostomy team. You can actually call them. They are centered in our ward, 7TD ward, led by our staff nurse called Staff Nurse Ram. So it is basically a tracheostomy team to handle all this teaching, seminars, CMEs. So they will, they have, I think this is something that has been going on for quite some time. So if you have problems with your patient, you can always refer to this particular team, or you can always refer to us in ENT clinic. We can always educate the patients and the family.
Yes, so we are coming up with a new flow for these patients. So we'll soon be putting it up in the PPUM website as to who you should contact. Any emergency, clearly you contact the ENT doctor on call. We have a tracheostomy nurse who is in charge of educating the nursing staff on each ward, and also the go-to person should you want to ask about any questions you have about trachea care, decannulation, any teaching sessions you want us to give. She'll be the go-to person. But we'll update the PPUM website with the new flow for trachea patients. Okay, we have another question. For suctioning, is it 1/3 of the suction tube to the opening of the tracheostomy tube at skin, or is it 1/3 from the end of the tube as per the inner tube? Presume it is the former.
Okay, for that question, yep, it is the former. But actually, for me, the best is actually to just, get one tracheostomy tube and just measure the suction tube with the tracheostomy tube. I think that is the best, even though we say 1/3, that is like the easiest way, but the best is actually to just take the tube and just, compare and, measure the length properly, because all tubes, the sizes are differently, the length is quite different, and we do have some other tubes like extended tubes and things like that. So the best is actually to just take the tube and then just, measure it to get with the tracheostomy tube.
Yes, thanks, Dr. Sakina. So we are coming up with a new bed signage that will explain the type of tube the patient has in them currently, and also the suction catheter size and length that is appropriate for that patient. So that's also coming up pretty soon. So there'll be a useful guide for anyone attending to the patient in an emergency situation. We have one question or one comment from Dr. Yu. I wonder how much of the poor care the patient received is due to failure of poor communication between medical providers and the son of the patient, plus also between the medical providers themselves. Absolutely, totally agree 100%.
Yeah.
Communication is key, not only with tracheostomy tube, but in anything that we're dealing with patients. So is for us to communicate better with not only patients, but their family members.
Yeah.
Okay, any other questions? Let me see. Okay. Okay, we'll take this final question. Are some patients inherently poorer candidates from tracheostomy tubes? Can difficulties with secretion care be anticipated or foreseen? It sometimes feels like secretions can sometimes be a vicious cycle: secretion, suction, mucosal irritation. Yeah.
Yeah. Well, there are some patients where we can expect they have more secretions, like a big bowel patient with, multiple comorbids and all that. But, well, nothing can be done apart from, a proper physiotherapy, rehabilitations and all that. So, well, for me, the best thing is basically, nursing care should be, we should maximize the nursing care. Whenever infection comes, we settle the infection. There's nothing shortcut about, this tracheostomy care and how to handle it. For me, it's just nursing care, and, I think that's the best. What do you think, Prof?
Yeah, one is good nursing care. Two is we have to remember that we are bypassing our nose and mouth that humidifies the air. Okay, so when we put in a trachea, that ability for the body to humidify the air is gone. Hence why the secretions become thick. So sometimes just saline nebulizer, 2 or 3 times a day will also help reduce this problem. We have HME, which is to humidify. It's a device that you can put on the tracheostomy. Again, it involves cost. So if the patient is able to afford it, it's something worth looking into, where it is able to humidify the air to prevent this. Is there an alternative? Best is patient's own airway. Clearly, we are very selective in who we put tracheostomy tubes in, hence why there's always a multidisciplinary team meeting, discussion with the family. So we are very careful in who we put the tracheostomy tube in. And currently there's no other alternative.
Yep.
Okay, so this brings us to the end of this session. Thank you, everybody. And thank you, Dr. Sakina, for
Thank you so much for
educating us. Have a good day, everyone. Thank you.
Thank you.